Good evening. My name is Hunter Reckonard, and tonight I'm going to be talking to you about the conservative treatment of synovial plica in the knee compared to the surgical treatment. There we go. So first, I'm going to be talking a little bit about the outline of how tonight's presentation is going to go. I'm going to start with an introduction of plica in the knee, what it is, and the treatment options. From there, I'm going to go into the focus clinical question, then into the search strategy, which will then lead to the overview of the included studies. From there, we're going to look at the clinical bottom line and then future implications. So pathological synovial syndrome is developed during embryogenic phase of development. Plica are typically involuted during the 12th week of fetal development and remain 50% of the population after birth. It's particularly problematic if you're physically active because they are painful during physical activity and can become irritated and inflamed. And if you have an irritated or inflamed plica in your knee and are having pain, then you're not performing at your best possible, and you are going to be in pain during it, which is not ideal. And right now, there are two main types of treatment: conservative and surgical. So my focus clinical question is the conservative treatment of pathological synovial plica syndrome successful, or should doctors perform the surgical option earlier in treatment? My search strategy to get the articles for this presentation and paper were articles that were research studies, articles that measured the outcomes of conservative treatment, articles that measured the outcomes of surgical treatment, and articles that focus on synovial plica syndrome. The exclusion criteria were articles that were reviews of literature, articles that looked at more than just synovial plica syndrome outcomes, and articles that are currently inaccessible. I searched Google Scholar and excluded many studies based off content, mainly because they were about plica in the elbow, not the knee. When I eliminated all of those, I was left with 15 and used exclusion criteria to narrow it down to 8. And then I excluded 2 based off the content of their abstract. They appeared that they were going to be a research study, but then in the end didn't really study anything or look at anything and just talked about synovial plica in the knee and their causes. So I kept 6 articles that did have a study and did have outcomes to look at. And then I excluded 2 based off their availability. They were unavailable for me to look at. Therefore, I couldn't use them. So I kept 4 total. And these are the studies I kept. So the first one was the arthroscopic treatment of the symptomatic synovial plica of the knee, long-term follow-up. The participants in this study were 51 patients who had arthroscopic surgery for synovial plica and did not experience any other knee condition. All patients had 6 weeks of conservative treatment prior. There were 31 males and 13 female patients, and the mean age was 24.9 years old. And the follow-up average was 46.8 months post-operation. The outcomes measured patient symptoms and ability to return to activity and rated them as excellent, good, or poor. Reported results were 22 excellent, 16 good, and 13 poor, and no one reported worsening results. The conclusion was that the surgical treatment had 74% of positive results that led to little or no symptoms and returned to physical activity. This was an observational study, had a level of evidence of 1 and a 14 out of 22 on the Strobe evidence quality. The second article I kept was the arthroscopic excision of medial plica, a meta-analysis of outcomes. The participants were studies that observed knees that had arthroscopic surgery for medial plicas, and the patients were older than 15. The outcomes were once again rated as excellent, good, fair, and poor on the scales of outcomes. The results were 643 knees had surgery for medial plica. Follow-ups took place between 4 and 87 months after. Mean ages fell between 25 and 45 years old. 7 studies showed favorable outcomes for arthroscopic surgery, good or excellent results in 84.2% of knees, and then 3 studies had conservative treatment done prior and had good or excellent results in 76.1% of cases. In conclusion, surgical treatment had from 84.2% to 76.1% of positive results that had little to no symptoms and returned to physical activity. This was a meta-analysis. It had level of evidence of 1, 17.5 out of 27 on the PRISMA evidence quality scale. The next article I looked at was the pathological synovial plica of the knee. The participants were 101 patients with synovial plica. 56 men were examined and 45 women. Ages range from 11 to 66 years old, and all patients were physically active. The objective was to decrease the compressive forces on the anterior compartment of the knee by increasing the structural flexibility of the joint, and good results were based off remission of symptoms. Average results were based off symptoms present during one type of physical activity, and poor results were given based off symptoms without improvement. So results from this study were evaluated 1 year, while follow-ups ranged from 1 to 3 years prior. So 55 knees were given good results, 27 knees were given average results, but 54 knees were given poor results. The conclusion was conservative treatment had almost equal amounts of good results and poor results. This was an experimental design study with a level of evidence of 1, 13 out of 22 on the Strobe evidence quality scale. And the final study that I included was the treatment of pathological synovial plica of the knee. The participants were 55 patients who were treated by just conservative measures. The mean age was 25.7 years old. The most frequent complaint was suprapatellar pain and cracking noises after physical activity. The outcome measures looked at patients' ability to return to physical activity and if they had residual symptoms. The results were 49 patients returned to physical activity without any more symptoms, and 6 patients returned to their physical activity with complaints that weren't incapacitation, which means that didn't prevent them from returning. They just were just still there. In conclusion, was conservative treatment had results where most patients could return to physical activity. This was experimental design with a level of evidence of 1, 13 out of 22 on the Strobe evidence quality scale. So clinical bottom line. There's conflicting results that demonstrate that some individuals find success in conservative treatment while they were almost the same number of patients that needed surgery after. A common factor in all surgical procedures done was that the conservative treatment failed. Based off the conflicting findings from the conservative treatment, I gave this a strength of recommendation of B. However, I did have good or consistent findings with surgical procedures done. The implications. So for future practice in a clinical setting, it should be looked at a case-by-case scenario when deciding if surgical or conservative. If conservative treatment is not working, do not keep trying to make it work. Go ahead and refer for surgical intervention earlier, especially if they're a D1 or a D2 athlete, if there's someone who's physically active quite often, if it's someone who isn't all that active, and when they are active, they have them, perhaps conservative treatment can still work, and you don't need to send for surgical intervention. It is all based on the athlete, and the athlete should be included in the decision. Education is going to be inform healthcare providers of both options and what the treatment and rehabilitation process looks like for both. Obviously, the rehabilitation process for post-surgical looks a little different than conservative, and clinicians and healthcare providers need to know that. And they also need to educate patients on their options and what recovery is going to look like. Let them help decide their treatment. Patient-centered care is important. And then research. Future research is needed. We need to perhaps figure out an ideal conservative protocol developed, including the length prior to referral, so that there is a across-the-board way to conservatively rehabilitate medial plica or just plica, and that we have a deadline for, hey, it's not working, let's go ahead and refer. And this should be reviewed in 2 years, this topic, to see if there's any new research or evidence that's come out that could sway it one way or the other. These are my references used throughout the presentation. And thank you. The quote I'm leaving everyone with is, the only thing I know is that I know nothing, from Socrates. And he said that while he was doing his own research. And the more he researched, the more he realized that, hey, he doesn't know a lot. And I thought, it was in the spirit of research. So thank you all so much for watching, and I hope you have a wonderful evening.